Evening. While we're waiting for others to join us, I would like to welcome all of you. This is the second of an expert chat, what we call the coffee and chai chats, around multiple micronutrient supplementation. My name is Marty van Lieren. I am the program lead of the Healthy Mothers, Healthy Baby Consortium, which is hosted by the Micronutrient Forum. The consortium aims to drive collective action to improve maternal nutrition, and more specifically by accelerating the introduction of MMS in settings where the diet is poor and where indicators on anemia and low birth weight are high, and where we believe that this supplementation can make a significant improvement in maternal nutrition status. Today is our second chat of this series. There's more to come afterwards on various MMS-related topics. And before I introduce our guest of today, I have a couple of more technical things on the format. The first thing is that I would like all of you to be muted, or we will mute you during the introduction of our guest. Our guest will speak for about 5-6 minutes, and during his introduction, you all will be muted. But once that introduction is over, we will unmute everybody so that you can ask questions and the discussion can be carried forward. Just raise your hand through the button or type your question in the chat, and we will give you the floor. Now, I can see that you all have your names in here. If possible, it would be great if you can also type your affiliation so that we see in the screen who is joining us and from which place. But the full name is already really great. We ask only the people that are talking to have their mics unmuted, so that everybody, even during the discussion, if you're not talking, please keep it on mute. That will keep the interference low. Then this total chat is very short, it's 30 minutes, and we would like to give everybody a chance to ask questions if you have them and to be part of this discussion. So if you have a question, please be very precise and short and to the point, so that others will also get a chance to ask questions. In case of any technical difficulties, please type this in the chat and we will have somebody of the team answering your questions. Now, I would like to introduce our very highly esteemed guest today, Dr. Zulfiqar Bhutta. I suppose many of you know him. Dr. Bhutta is the Robert Harding Inaugural Chair in the Global Child Health team of the Hospital for Sick Children Toronto, co-director also of the Center for Global Child Health, and the founding director of the Center of Excellence for Women and Child Health at Aga Khan University. Now, Professor Bhutta has authored countless publications in these areas on the topics of newborn and child survival, maternal and child undernutrition, and micronutrient deficiencies. And he is one of the lead authors of the Lancet Nutrition series. Today, Dr. Bhutta will speak to us about the evidence behind MMS. Zulfi, we're really delighted that you have the time and you made the time to be with us, and we're looking forward to a stimulating discussion. The floor is yours.
Thank you very much, Marty, and let me share my screen. I am, as indicated, delighted that we have this chat session. We don't have too many people, but as I can see, we have high quality folks out there. So just as we start, I just want to have a check that you can see my full screen.
Not yet. Not yet. We still see also your next slide. So
for some reason, I can't see the same as we had before. Maybe it's just the nature of.
If you go to display settings, that's no.
No, we had this before also. Show taskbar, display settings.
I think that's where you went before to.
Yeah, I mean, I can't see the display settings. That's what's odd.
Oh, it's okay. Gurmeet, can you help? Gurmeet?
Yeah. So if you can see on the top of your screen, there's a
Yeah, I
display
can't
setting.
see the display settings like before. Did you change anything?
No,
No,
we can
it
see
doesn't.
it actually. It's next to the
Okay.
show taskbar. I can see it.
I have asked for the remote control. If you can give me the access, I will change it.
Yeah, I mean, okay. All right, so why don't you put it on full screen if you don't mind?
Yeah,
Okay.
I'm trying to.
All right, so what I will do, colleagues, in the, oh, actually, yeah, I mean, I can see it now, so it had disappeared. So handle the slides, if you will, please. So
Yeah.
what I've been asked to share is some thoughts on multiple micronutrient in pregnancy, and what I intend to do is to maybe give you my views in the next 5 to 7 minutes, and then I hope that we can have a discussion. So I know we have a relatively small but a very highly regarded group, so I'm happy to answer questions and pose some questions to you of my own. So this has been a subject of interest for, gosh, almost 20 years now. Virtually from the time that the first Unimap trials were held under the auspices of UNICEF, looking at the simple question, can we have a better solution than iron folic acid supplementation in pregnancy? And the reason why iron folic acid supplementation in pregnancy came up was for several reasons. One, next slide, please. One is global anemia. If you look at anemia in women of reproductive age worldwide, it is one of the largest public health problems that we have, highly prevalent, particularly in low and middle income countries, but it's also not something that only clusters in the poorest of the poor. So it's ubiquitous. And in many places, iron deficiency anemia in particular, which is roughly around half of all anemia that we see, is resistant to the typical interventions that we have, such as supplementation, or in many places, fortification programs. So there's been a big question around what should we do with this. And in fact, my group is currently involved in looking at global exemplars as to which countries have been able to reduce anemia in women of reproductive age reasonably fast, and what were the attributes of that programmatic change. The other really is the more technically difficult challenge of working with a commodity that people don't like. So before I did pediatrics, I actually did obstetrics and gynecology, and I can tell you many practitioners of medicine who work with women of reproductive age and antenatal care will tell you that women don't like iron folic acid, particularly ferrous sulfate, which is just universally prescribed for a variety of reasons. Firstly, it's intolerance. Secondly, they are unable to take it at times because of not only dyspepsia, the perceived notion that it causes some abnormalities, changed stool discoloration with iron intake is still considered quite a problematic issue despite education. And thirdly, that there is what we call an attrition in programs in terms of the effectiveness and efficiency of iron folic acid supplementation programs. Let me illustrate that with one programmatic review data from India, where in a programmatic setting where this was prospectively evaluated, and I think it was Pat who looked at this analysis, you could see that between the time that women receive antenatal care and even with 80-90% coverage, that tells you that still 10% are left behind, and receive counseling, and then counseling specifically on iron folic acid and iron folic acid tablets for a particular duration, let's say 3 months, are distributed till consumption, there is a massive depreciation. And this is something that we encounter for the very simple reason that people don't take it, they don't like it, and program coverage of iron folic acid at best in many places ranges from about 20-30% to maximum 60-70%. So we have a commodity that is generally not well tolerated in pregnancy. There are some formulations, particularly of iron formulations, iron fumarate, ferrigluconate, that are better tolerated, but they're more expensive. The other issue is that in circumstances where we see iron deficiency and anemia, it reflects micronutrient deficiencies which are generally never isolated. So these are data from my home country of Pakistan, where in a variety of settings, we looked at the prevalence of multiple micronutrient deficiencies, 3 or more, micronutrient. In fact, in this slide, it's more than 3 micronutrient deficiencies in a sample of women of reproductive age. And over time, as you can see, close to around 16, 17% of all of these women have multiple micronutrient deficiencies, whether they are urban or rural. And these you cannot control with this iron folic acid alone. So a big question around the entire evidence of whether or not we should replace iron folic acid with a different commodity, the genesis of the Unimap trials many years ago was around trying to do something better than iron folic acid for these programs. And we've looked at this evidence over time quite sequentially. So for example, we have, this is now the 5th iteration of the Cochrane review that my group has done with multiple micronutrients in pregnancy, looking at all kinds of issues, including dosage, including age groups, including women of different risk groups, and also importantly, formulations. And in the most recent iteration of this review from 2019, we actually specifically generated data which looked at Unimap formulations versus other formulations also. So I'm going to today talk about the standard formulation that are available in many places, providing at least 1 extra RDA a day. And it does seem to have, in circumstances where you compare iron folic acid and multiple micronutrients, almost the same benefit, despite the fact that it has a lower dose of iron, daily dose. And the reason is that it has additional things that promote iron absorption, vitamin C, for example, and it does also provide additional micronutrients. And if you look at the impact in terms of reduction of anemia, versus placebo, which are relatively few studies because it would be ethically very challenging to do these kind of studies now, we see a benefit in terms of anemia reduction, which is a little lower than iron folic acid in general, but also around 40% or thereabouts. So it works for anemia. And in this case, it's 3rd trimester anemia, which includes some of the dilution effect. But we have a subset of studies where this was also assessed postnatally. The main important benefits that we are seeing with comparable impacts on anemia of multiple micronutrients is improved fetal growth. So you see an effect of low birth weight reduction here overall, around 12 to 15% reduction and significant. We see that a large chunk of that is potentially related to a combination of an impact on prematurity as well as IUGR. Now, in the most recent review, we don't see an effect on prematurity. This was largely driven by a large study done by Keith West and colleagues in Bangladesh. But nevertheless, it appears to have some effect on gestational age and pregnancy duration as well. But the bulk of the impact that we see still remaining significant with a wide range of these data are on IUGR, especially small for gestational age birth. So it improves fetal growth. And overall, if you look at the benefits of the totality of the multiple micronutrient experience, the impact in terms of low birth weight and SGA reduction are between 8 to 12%, let's say 10% on average. Now that may not be massive, but at a population level, you can well imagine reducing SGA by 10% can have huge benefits, both in terms of survival, in terms of long-term outcomes, such as child development, and risks of non-communicable disease. Most recently, and this is my last slide, we have looked at this in subgroups. So in an IPD that we published with funding from the Gates Foundation, we looked at individual participant data analysis, not just aggregated analysis that investigators provided, but we actually looked at data sets. So we looked at metadata here, 1-stage and 2-stage analyses. So look at the 1-stage analysis, which is basically straight away looking at the data in totality. It is effective and appears to be slightly more effective in women or girls below 18 years of age. So that does mean that in certain subgroups, replacing and replenishing multiple micronutrients may have benefits. Now, overall, you can argue that 13 versus 24% reduction in small for gestational age births by multiple micronutrients may not be very different. But I do think you see this as an age effect, which reflects many at-risk subgroups for deficits and adverse outcomes. So to cut a long story short, we have a commodity that has now been studied for almost 2 decades in both small studies, trials, as well as large programmatic settings. Now, what were the issues that had led to some global disquiet on this? There was some signal earlier on from studies in South Asia in particular, that there may be an increase or excess neonatal mortality associated with multiple micronutrient supplementations, partly through a pathway of having larger babies in small women, and therefore higher risks of obstructed labor or birth asphyxia. And that's not a trivial question. But large-scale subsequent studies have failed to show that. And we certainly published an analysis a few years ago where we looked at outcomes with adequate skilled birth attendance or maternal support versus inadequate maternal support. And there's no question, most of the signals were from settings where maternal support was inadequate. So therefore, if you want to increase birth size and fetal growth and potentially large for gestational age babies, may increase in a given population, you have to provide maternal care. And therefore, this is not an intervention to be done where mothers would not have access to adequate skilled attendance and facility birth. The second is a question of costs, and I'd be very happy to discuss that with people. Is the cost worth the squeeze? The third is ancillary benefits. I mean, are you looking at some benefits from multiple micronutrients? And there is some signal that the developmental benefits may be a little better, but it is not a massive signal which is uniform across all populations. So it does depend upon which context you're doing this in. So let me stop at this and see if there are any questions and comments, and I'll be very happy to take those as we take this forward. Thank you. Marty, over to you to coordinate this.
Right, thank you very much. I actually have not seen yet specific questions. Let me see if there's any hands up. There's a full screen, so I'm not seeing at this moment any hands up. But while people are reflecting on what you've just said, can I ask you already one question? Because you said, it's not a massive signal and it is definitely context specific. But could you just elaborate a little bit? Because 12% reduction in low birth weight in certain settings where we do see very high low birth weight rates could be massive. It
is massive. Overall, in a global context, if you take low and middle income countries, Marty, where we have almost 25–30% of all births in some settings being IUGR or small for days, and with the disproportionate mortality associated with this, you're looking at millions of births. I mean, our crude estimation some years ago of SGA births worldwide were between 30 to 50 million births annually. So 10% of that is not trivial. And especially when you're looking at developmental benefits overall, I mean, those benefits are not just to survival, they're also to long-term development. Now, admittedly, we don't have enough data from our cohorts on the effect of multiple micronutrients on long-term outcomes. But I think if you have benefits in terms of status at birth, you can easily extrapolate from other information as to what advantage that may have for populations. So I don't think a 10% reduction is trivial, especially if it's significant, especially if it's reasonably consistent across populations. And it's for countries to decide if that's worth the squeeze and if they have anything else which is better. So, one of the things we need to look at is what else can improve low birth weight or SGA in a reasonable amount of time without necessarily massive secular trends in economic development.
That's a really good point. And though I'd love to elaborate on that, I do think what you're saying also is that introduction of the supplementation, we really need to accompany that with strengthening of antenatal care services across the board. I mean, the nutrition services, and not just as a standalone, most likely.
So I see a number of questions in chat. Shall I just pick them up, Marty, or will you?
Yeah, they started coming in. So there's one question, you can pick them up, but there's one person that says, can we add the iron folate supplementation on top of the MMS to reduce anemia?
No, we shouldn't. What's up, that would not be advisable because you would actually negate all the benefit of giving a lower dose of iron. Remember that iron supplementation, iron's a drug. And as you will see very soon from a paper that's coming out in Nature, when you give iron to children, particularly pharmacological iron, you have to be very aware of the potential negative impacts that may have in subsets of population. So it's not a trivial thing to be giving iron per se, and therefore the multiple micronutrients were developed to be able to reduce the amount of iron that you give in pregnancy with greater bioavailability. So you get better value for money for a particular formulation. And that's what we see in practice also. So you should not be giving extra iron when you're using multiple micronutrients.
Yeah, there's also the following question is about the treatment or the medication for anemia, but I suppose that it is meant severe anemia.
Yeah, this is not the treatment for severe anemia. As you know, we are moving towards innovations, and the Gates Foundation has in particular been very proactive in looking at alternative management strategies for severe anemia in women that include also intravenous administration of iron. So I think there are alternative strategies for treatment of severe anemia, which are going to come, but giving a low dose of iron every day or iron fortified products is not treatment of anemia. This is generally for prevention of anemia.
Right. And Saskia van der Kam, who is working in emergency setting, is asking whether you have any suggestions to increase the availability of MMS for pregnant and lactating women. I mean, this at the moment is, of course, one of the restrictions, right?
So let me spend a minute. So the great question. And my suggestion for increasing the availability of this is, number one, we need to continue to work with WHO to make sure that the recommendation for the use of multiple micronutrients in pregnancy isn't guarded, isn't conditional, and is pretty straightforward in terms of its safety. Now, number one. Number two, I think this is related to economies of scale. If these become available at scale, the price differential that we currently have between iron, folic acid, and multiple micronutrients will disappear over time. I mean, the price differential is marginal for the benefits that you get. And we have very clear evidence from multiple micronutrient administration that you get benefits on multiple micronutrient status. For example, we see vitamin D status improving, we see vitamin A status improving in women of reproductive age, and even zinc status improving. So there are advantages to using a formulation like this. What will it take to increase its availability and scale is concerted global advocacy. And I think some large scale introductions in pilot countries or countries that are willing to do this. I know Khwaja Masood is online from Pakistan. The Pakistan government has been very keen to see if we can potentially introduce this in populations, because this was also initially tested in Pakistan as well. And if we have evidence in terms of its benefit and safety in those settings, as well as affordability through proper channels, I think you will see this scaling up. I'll say one more thing. This is one of the most inequitable interventions worldwide. People, women of reproductive age, pregnant women who are rich, come from rich socioeconomic groups in countries, are already receiving multiple micronutrients. There's not a single woman that I know in obstetric practice who receives iron folic acid only. In most places, the private practitioners and the obstetricians will prescribe iron folic acid plus other things. And there are lots and lots of these commercial formulations of various denominations available that people use. They're all very expensive because they are from the commercial side of the pharma industry. So the difference between the urban and rural populations, the rich and the poor, is around what they get and what they buy out of their pocket. So the whole idea of developing this at public health level and scale is to reduce that equity gap that we currently have between the rich and the poor, because the rich already have this situation.
That is a great point. I really like that. There are two questions that are related to adherence. So do we already have evidence whether MMS shows higher adherence rates than IFA? And then a bit down, there's a question of, does it have similar side effects or adverse effects as IFA? And do we have any evidence on that?
So this is a great question, and it's a question that I think we need more programmatic evidence from. So far, from the trials and introductions, the evidence is that it's tolerated better than iron folic acid. But trial settings are trial settings, so I would much rather see it in effectiveness trials. So we have recently completed a large multiple micronutrient supplementation study with additional interventions in adolescent girls and young women in rural Pakistan. Naveed Bhutta is online. He would remember that from Matyari. We've just finished that. And we are looking at adherence and compliance in that because it was done in an effectiveness setting with lady health workers. And looks at as if, there may be subgroups who don't like taking multiple micronutrients also, and we're trying to explore why. But this is something that needs to be studied at scale in the right settings.
Yeah, and there's quite a lot of the implementation or introduction of MMS that's accompanied by implementation research looking at similar questions, I believe. Another question is, what is your opinion on the use of MMS pre-conception?
Oh, as I said, I've just done a study on this. So we need more data, but the idea, so as you know, there is a recommendation, there is good guidance on the use of iron folic acid in non-pregnant women, young adolescent girls, once weekly. That evidence and recommendation is there as a WHO guideline. Now, the question is, can that be replaced by multiple micronutrients? And even if you don't give it once weekly, give it twice weekly. So we've just finished that trial, as I said, and we would be looking at some of that data. But theoretically, there is no reason why multiple micronutrients in a multiple micronutrient deficient population should not replace iron folic acid. And then it will become easier from a program point of view because you have just one commodity that goes from pre-pregnancy to pregnancy and beyond.
Mm-hmm. There is a question of Phil James of the Emergency Nutrition Network that the latest data on the global burden of anemia is from 2016. And that's still included in the latest GNR report. Are you aware of any plans to update the estimates of the global burden?
I mean, there are lots of data, Phil, that are coming in, and yes, it should be updated. The other thing that I would very strongly recommend is that we should stop modeling anemia data, because when our Exemplars project has shown this very clearly, that, we've selected countries for the in-depth studies based on model data and what we have overall. When we have gone in and looked at actual data on the ground, the progress has not been as rosy as people made out. So I think we need more subnational data. There are now more studies being done in countries, large countries, which allow us to look at subnational burden, which allow us to look and differentiate anemia from iron deficiency anemia, anemia associated with other micronutrient deficiencies. So I think yes, and if somebody's listening from WHO, I think this is on their radar screen also, that we need updated data on global anemia burden. With our Exemplars work, we would be generating something which is, at least at a country level, better than what the UN estimates are, but more is needed.
Right, and as you are probably aware of, the Global Exemplars are also joining a still to be set up global alliance for anemia actions that will be set up with WHO and UNICEF in the run towards nutrition for growth. And we hope that that might also make some changes. We have 2 minutes, I believe, and we haven't had all the questions answered, but I just would like to put forward to you that there's a challenge that Saskia puts forward on how can we challenge WHO more to recommend or update the recommendations on to really recommend MMS over IFA instead of the other way around. Now, you are definitely aware, like many of on the call, that MMS is now included in the model WHO essential medicine list. So do you think that that's a good step forward, or is more to be done?
Obviously, more needs to be done. But, I've also learned the hard way over the years that the one thing that you don't do is to bulldoze WHO into anything. You get the opposite reaction. So I'll give you my 2 pennies worth, and then unfortunately, because I have a hard stop, I'll beg leave. But what I would recommend, Marty, is if there are questions in chat, and I see many, please send them to me and I'll answer those individually or collectively by email. So what do we do with WHO? Firstly, I think work with them. I think this is a scientific question. It needs to be asked scientifically. But WHO guidelines groups consider not only the hard science, they also look at a variety of other things, including feasibility, implementation, cost benefits. And I think what we need now is to expand the global evidence at the same time as we work with WHO on revisiting their guidance. My sense is that the guidance was revisited just a couple of years ago, so it will be another couple of years before we see WHO reassemble its guidelines reference group on antenatal care to change this. But they have already given elbow room for this use of multiple micronutrients at country level through a discussion with countries on feasibility and on generating additional information that will influence policy. That's why Pakistan is looking at it right now. That's why other countries are looking at this right now. So as you know, this is basically WHO as a normative group will change normative guidance based on evidence. And I'm suggesting that we look at potentially working with them on improving the collation of the evidence, on generating the evidence from large-scale introductions, and the implementation research that is needed to inform WHO policy. So it's, I don't think we should be protesting outside of WHO headquarters to say, do this tomorrow. I think we should work with them sensibly and collectively to say, how can we plug the evidence gaps that you think are needed to make this global uniform policy? What kind of research would help assuage some of the concerns? And some of those concerns cannot be assuaged without introduction. So we need to get more clarity in terms of support for large-scale introductions in countries. I think we already have it from the global guidance document. And that's why in the Lancet series, I very clearly recommended that we move to that level of implementation.
Thank you very much. It's 3 o'clock or 9 a.m. in the East Coast. I know you have to go. Thank you very much for being here. We will collect the questions as we do for all the other chats. We would like to draw a frequently answered questions document from that. So we will share it with you. If you want to provide answers, we can also then collectively share it with people that are on this call.
I see many familiar names, and I think if there are questions that I can contribute answers to, I'll be happy to do that by email, Marty. Thank you very much for the opportunity. Take care.
Thank you very much. And I would like to thank all the participants here. I would like to say also that the Healthy Mothers, Healthy Babies Consortium has been set up for helping to drive the advocacy on this topic and engaging with the various partners. So you can also ask questions to us and maybe join us later this week. We have another chat coming up between Saskia Ozendarp, the Executive Director of the Micronutrient Forum, and Dr. Hema Divakar, who used to be the chair of FIGO, the Gynecology's Obstetrician Organization in India, and he is still very active in this setting. We will also have a session on maternal nutrition and MMS at FIGO, which is accessible for those who are working in the maternal health field and may have registered at their World Congress. So please keep looking at the rest of the chats that are upcoming. We have one on Thursday, we have one next week, and we have a couple of them in November. So thank you all for being there, and looking forward to connect the next time. And Rijuta, I hope you have collected all the questions.
Yes,
so
they've all been saved. Thank you.
Absolutely. Thank you very much. And a big thank you to everybody that was there, a couple of well-known names. So let's connect, and also outside the expert chats.